Those of you who are listening to us and watching us on YouTube, you're behind the curtain, behind the scenes, backstage with our all-star panel. We're going to go live with our Zoom audience and for our podcast audience in just about 60 seconds. Formal. Those of you who are listening to us and watching us on YouTube. And that's one of the reasons I have to do it ahead of time. I learned that the hard way. Okay. We're at 11:30, folks. We're jammed. I'm going to get us going, okay? So I'm going to pull up the curtain if that's okay with everyone.
Great.
We'll go from there. Sherry, you got the Q&A, and I'll look at Q&A, and you guys have the chat. If you want to communicate with me, just be wary of who you're sending the chat out to, because you could send it out to the entire audience. All right. And away we go. Greetings, everyone, and welcome. This is Eric Glazer, and you are listening to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together not only to inform you, the audience, but to also unearth bright spots, successes at health plans, providers, and various other healthcare organizations across the country. Our goal is to identify as many success stories, as many bright spots as possible, so that you, the listener, can determine if these ideas, these programs, these strategies are scalable and applicable at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. Today is crazy jammed. We have an unbelievable panel covering an unbelievable topic entitled Reimagining the Consumer Experience, Leveraging Empathy to Drive Healthcare Innovation. In order to get the most content and ideas out to you and maintain our promise of keeping you only 60 minutes, we are going to jump right into it. You have received an email with our panelist bios. You have also going to see a text or a chat on your Zoom interface with a link to the bios. Take a look to see the great experience and skill set and information you're about to receive from this incredible group of 5 panelists. We are going to we're not going to take live questions as we typically don't, but you have a Q&A module at the bottom of your screen. You could type them in. We'll do our best to incorporate those into the course of today's conversation, although I will warn you, we are pretty tight on time today. So I'm going to jump right into it. Your panelists represent unbelievable organizations: Stanford Health, University of Pittsburgh Medical Center, Commonwealth Care Alliance, and the Center to Advance Consumer Partnerships, Barnes Jewish Hospital, and of course, Nemours Children's Hospital in Florida. We're going to bring them all into the discussion. I'm going to start with what I call an icebreaker and talk about why empathy. Why empathy, and what is the methodology to leveraging empathy as part of your overall organization strategy? And to do that, I'm going to bring in our first panelist, Stephanie Massari, who's the director of innovation, the Innovation Center at UPMC. Steph, take it away. Why empathy at UPMC?
Sure. Thanks, Eric. It's a privilege to be here today. So why empathy? Empathy is the ability to really understand, to share those feelings, and to really be fully informed. It doesn't necessarily mean that we always agree, but it is a way to be fully informed is the key there. It is a way to ask those questions, not to have the answers to the questions, to be that facilitator in engaging in active conversation with others. So empathy really is the core of healthcare. Obviously, care is key, but empathy, I like to say, is the basis. It's the relationships, the people. And the methodology piece that we utilize is called the patient-centered value system. It's a methodology that really engages the patients at the core, along with employees and all stakeholders, to simply create measurable and sustainable change. And our efforts really focus on the co-design and the team building piece that really support empathy, the whole key behind everything. And really, the patient-centered value system was created by our medical director, Dr. Tony DeGioia, who's a practicing orthopedic surgeon and engineer who really developed this in his practice with his team. And the idea was to create the best possible experiences, outcomes, financial and clinical outcomes for his patients. And we figured, how can we really encourage this methodology and deploy this on a larger scale outside of orthopedics? So that is how we really like to scale and utilize empathy, and use that as a collaborative resource across the system with our partners.
An empathetic orthopedic surgeon. That's innovation.
It is.
So let's and right away, folks, if you were just joining us, Q&A module at the bottom of the screen. You can help me moderate, throw in some questions. We'll incorporate it into the conversation as appropriate. Let's talk about the difference. So as I researched this topic and got ready for today's episode, I didn't realize there were sort of different ways of addressing empathy at a business level. There's individual empathy and there's organizational empathy, as I was taught. So I'm going to bring in Melinda Karp, who is the executive director of the consumer partnership. Excuse me, sorry about that. The Center of Advanced Consumer Partnership, which is part of the Commonwealth Care Alliance in Massachusetts. Melinda, how do you distinguish between the two? What is the difference between the two, so everyone here could understand better?
Sure, Eric. It's a great question. And really, individual empathy is a key ingredient to organizational empathy. And as Stephanie already laid out at UPMC, it really is all about, at the end of the day, the patients and the individuals who serve them. The difference between what happens at an individual level with empathy and what happens at an organizational level is really about scale and therefore impact. So as Stephanie described, if individual empathy is really walking in someone else's shoes, being able to hear and listen to a problem or an issue through another person's lens, and then reacting or responding through that lens, not your own lens, but the lens of the person who you're engaging with, then organizational empathy is really about taking that up a number of notches to the whole organization and partnering in an ongoing way with those who you serve to really understand both what those you serve are experiencing, how they feel about it, what's really important to them, and then your ability as an organization to translate that into actions and decision making. And Stephanie really already laid out one model at an organizational level for that infrastructure that one needs to have to create organizational empathy, so that it goes beyond what's happening behind the exam room door with or in someone's home with one individual and one care provider, to really the organizational culture as a whole being an empathic culture.
Interesting. Again, questions, follow-ups for Melinda, shoot them through the Q&A module. Could you provide, I'm going to bring in Alpa Viaz. She is the Vice President of Patient Experience at Stanford Healthcare, getting up a little earlier with us. Alpa, could you provide an example of how empathy is being incorporated at Stanford?
Absolutely. Well, Stephanie and Melinda certainly set the stage for hopefully an example that I can give. One that we use here at Stanford Healthcare. So we have a very similar type of framework. We call it CI Care. This is our behavioral and communications framework that we use. It's a mnemonic. It really stands for connect, introduce, communicate, ask, respond, and exit courteously. And this is the frame for which we've actually built our patient experience and kind of service excellence model. And the way we kind of brought this concept to the enterprise level, as Melinda talked about, was really incorporating it as a part of our leadership culture. So at Stanford, on a monthly basis, of course, given COVID, we've had to think differently about how we actually bring the entire management team together. But prior to COVID, about 700 to 800 managers across our entire system would come together on a monthly basis on a given date and time. Usually it's the third Tuesday of every month from 10 to 11:30. We as a management team get together. Our chief executive officer typically starts our rounding program where managers are really asked to round in areas outside of their own, to have a chance to connect with patients, family members, staff members, to talk about patient experience, to, as Melinda and Stephanie said, to really have a chance to walk in the shoes of those that we serve and that we care for. And we do this by rounding, and it's a fairly prescribed process in the sense that We collect information, we ask open-ended questions, collect that feedback, and as a part of our management rounds experience, we then all come back together and debrief on what we learned. And as the patient experience team, it really gives us an opportunity to hear everything that's happening in the organization and then work with our colleagues to actually problem solve. So it offers us an opportunity to understand real time what's happening in the organization, as well as even provide service recovery if we're not meeting expectations of our patients, families, and visitors.
The acronym CI Care, right?
CI Care. Mm-hmm.
Connect, introduce, communicate, ask, respond, exit courteously, right?
Mm-hmm.
Took good notes. So that someone was just someone in the audience was just asking about that. Hopefully that answers their question. So I imagine as we're trying to take this very human-centric approach to healthcare and that social determinants of health is an important part of understanding truly and empathizing truly with a consumer. So I want to bring in Rose to answer this question. Rose Carrion is the patient experience manager at New Morris Children's Health System. How are you leveraging, Rose, social determinants to drive towards becoming an empathetic organization?
So, that's a really big question, but I'll summate it to this. We really want to redefine children's health. And so we have to understand in medicine that it's more than just the biology. And so that's why we're using the social determinants of health, because it takes into understanding that the psychosocial components are just as important of an indicator for children's health as the biology. So we'll use an example that we've done. We did this program in 2006. Let's talk about literacy. We know that literacy is one of the biggest indicators of future health for children. And so we started a Bright Start program, which is a reading literacy program. So that's one way that we've incorporated a program throughout our enterprise to really focus on social determinants of health. And now we're changing our primary care practices to focus on these indicators and move to value-based care instead of fee-for-service. So we're really changing the model of how we're being reimbursed and providing care for our patients and families. It's really shifting our entire culture.
Interesting. I want to bring in our token physician, Dr. Andy Jody, who's an ER doc and an advisor at Barnes-Jewish Hospital, as well as a professor of emergency medicine at Washington University School of Medicine. Randy, could you talk a little bit about what you're doing at Barnes-Jewish around SDOH and moving towards an empathetic organization?
Sure, Eric, and thanks, and good morning, everybody. So I'm going to touch base on, we have a program called Familiar Faces with a branch within that called Hospital Housing, but the program arose from kind of a grassroots request from staff in the emergency department, inpatient beds, ICUs, and hospital administration in terms of familiar faces, patients who are perhaps more familiar than we thought they needed to be based on their clinical needs. They were there a lot. And the request really figure out, why are they there? What are the determinants that are leading them to be there? And can we help them with their true needs? So that the hospital housing is a subset of that. And that is a program in which we identify patients who are very frequent visitors to the emergency department through a review of our EPIC electronic medical record program, top 20 visitors in the last 30 days or 90 days. And then we also determine if they have either a qualifying condition of substance use disorder or behavioral mental health disorder. And thirdly, if they're homeless. And if they have those criteria, it's a voluntary program. We offer them the opportunity to have long-term housing with wraparound case management services with we St. Patrick's Center in St. Louis. We contract with them. And the metrics we follow are resource utilization, emergency department visits, inpatient days, readmission rates. We also follow the impact on the hospital finances for this subpopulation of patients before and after the program. And we also follow their stories. And just very briefly, in terms of the first two components, utilization finances, these patients average as a group of 38 visits per year at our emergency department, 44 at our system, and 60 visits per year regionally. before implementation of the program. These visits dropped anywhere from 62 to 66 to 59%. So they stopped coming to the emergency department broadly with the implementation of the program by meeting these other needs. In terms of inpatient days, they averaged almost 14 days per year at our hospital and up to 17 regionally. Inpatient bed days dropped 61 to 67%. Many of these patients had chronic medical conditions that still justified being admitted, but we also had better access to outpatient care, and they weren't being admitted for social reasons, social determinants of health. We also working hard on a readmission rate, and rates of readmission for this population dropped from 50 to 59%. We did have, we followed hospital finances, and I actually never even took a finance course or accounting, but we had actually our chief financial officer review these ultimately. And we compared, it was the impact on the margin for this subset of patients, basically taking, and most of these patients are either self-pay or they're state Medicaid. So the reimbursement we get is not sufficient for the cost of care. And the impact was that it dropped the cost. Basically, if you apply the net revenue they generated to the cost of care, there's a 71.1% drop in cost from the program. And the patients stopped coming. So it really was one of those win-win-win solutions. And and many of the providers knew what they needed, but it was very impactful on their lives and actually creating capacity, improving the bottom margin, the bottom line at the institution.
So I just want to break that down if I can, and just catch me if I go off here, Randy. So familiar faces, you focus on them, you use the some technology, your EMR, to identify the familiar faces that may qualify based upon sort of the different comorbidities you're looking at, like homelessness and BH or substance abuse, and you enroll them into this program. And even though you are incurring costs and in the spirit of just, you know, P&L, still for that particular case, maybe not getting reimbursed for everything you're providing. So it looks like you're losing money. The truth is the fact that these are such frequent visitors of the ED, you're actually saving over 71% by investing up front.
Saving. They are going to keep on coming back to our medical campus for care. They come back much less, and we provide their care at a much reduced cost. So, it was a very positive financial impact on the institution and their lives.
And before I move off, I just want to make sure, Rose, similar, but you're dealing with pediatrics and caregivers. Is there any story or example you want to share of sort of like your program in practice as someone comes in to the hospital there, where you use social determinants to truly get a full picture? You don't have to use real names, but I don't know if you had a story or anything you wanted to share.
Well, I'd actually like to share the story of our new CEO, Larry Moss, when he joined. And, it's to his credit that we're really pushing now even further the social determinants of health in our care and how we're changing our practices. But he had a patient who died of a gunshot wound. His patient's name was Jamal. And when he talked to the patient's mom, Jamal's mother, she said he died of asthma. And the reason that she said he died of asthma is because he was being left behind in school from hospital stays, from, not being able to control the asthma. And so he fell in with the wrong crowd, and then he subsequently died of a gunshot wound. And so this child died while being treated. And so he fell through the cracks. And so once you understand that children are falling through the cracks from this standpoint, from a condition that can be really managed really well, and passing, we really have to change to make sure that we are also ensuring that we're taking care of the social aspect. How are we impacting their health care? And so we teach empathy as a communication skill internally. And we know that safety issues derive from communication. So we really strive to improve our communication and build trusting relationships so that we can get this kind of information for our patients and families and really treat the whole child and the family. You can't treat a child without really understanding what's happening in the home, in the household. So we really...
I know, tell me if you don't have this at your fingertips, because going a little bit off script, so I think being able to build trust with a family, especially when you're dealing with pediatrics and adolescents. Obviously so important, and being able to understand everything that's going on in their life besides the clinical components, obviously so critical. How do you have any, how do you get all that information?
So we use the biopsychosocial patient-centered interview, and I teach that across the enterprise. So we teach empathy at the clinical level with our we bring in groups of staff together as a team, and we teach this and we practice this. And then, like Steph said, we do rounding across the facility and do train the trainer. And we're really trying to change the way we have the conversation in clinic with our patients and families. So, you know, we talk about the finances driving the volume. We're trying to change the way we're conversing with our patients and families across the entire system.
Really interesting, really interesting. Great stuff. Thank you for that. That was great. I want to just a quick little intermission. I want to just make a comment and an announcement. Just, you know, I'm really proud of the fact that we continue to grow the Bright Spots in Healthcare show. If you haven't subscribed and rated us, please go onto your app and do so. We really appreciate all the support. We're able to produce these programs almost one a week, not charge and do all of that because I have a great team and a lot of platforms behind me that does all the hard work. Many of you know I have a day job. This is just a labor of love. And so to be able to grow this program and provide a great panel like you see in front of you, I can only do it through corporate support. And I'm just so humbled by the outpouring support from corporations around the country who have supported Bright Spots in healthcare. And I want to give a quick and very sincere thank you to the Center to Advance Consumer Partnerships, CACP, who Melinda represents, who is supporting this episode, and just tell you quickly about the cool thing they're doing. So CACP helps companies and organizations across the country realize the untapped value of the consumer's voice. But here's what makes this super cool. So they have built on proven approaches at Commonwealth Care Alliance. So if you're not from Massachusetts, CCA, Commonwealth Care Alliance, is a non-for-profit community-based healthcare organization, and they focus specifically on improving the care for individuals who are dual eligible, Medicaid and Medicare, with complex medical, behavioral, and social needs. So they have identified or created a bright spot at CCA and then formed the Center to Advance Consumer Partnerships to clone those bright spots across the country to hospitals and health systems that need it. So CACP, if you haven't heard of them, guesses you haven't, they work with innovative organizations all across the country, human and healthcare and human service leaders who want to build capabilities, build infrastructure, and cultivate relationships that actually ensure that consumers, these human beings with the most significant needs, become enduring organizational partners to all of you. So imagine creating an invaluable strategy and action plan with these consumers. So together as partners, organizations, and consumers, you're inspired to build this really culturally inspiring trust and build solutions in a co-designed manner that really work to improve outcomes and enhance the experience. So when you're thinking about like finding a bright spot and cloning it, I can't think of a better example of CACP. So if you want to learn more about what they're doing, it's you can find them on the web at consumerpartnership.org, or reach out to me and I could put you in touch with Melinda. She's got a team that's great at scheduling her. You could pick her brain, learn about what they're doing, and learn about all the expertise she has in doing this. She's an absolute wealth of information. Coincidentally or not, the next question I have in our sort of discussion here is for Melinda. And I want, Melinda, if you could provide the group some steps on how you create an empathetic organization. How are you going about that, both at CCA and beyond CCA?
Sure. Thanks, Eric. And actually my colleagues on the panel who've already spoken have given some really rich examples of how each of your organizations are building empathy, and you know, to sort of bring it up from some of the specific great examples that we've heard. You know, as with most things, it comes down to people, process, and technology. And you know, when we starting just with the people, there's the employee side and thinking about really, well, who are you hiring in your organization and how are you about who you're hiring. And then when you hire someone, how are you onboarding them so that from the first day that they walk into your setting, they actually have a lens into the context and the experiences that the people you serve are facing every single day. And there are lots of ways to do that. But that, the people that are in the organization, as I said, individual empathy is a key ingredient to getting to organizational empathy. So who you choose to hire and the qualities they have, and then how you actually really get them, help them to be knowledgeable and to literally walk in the shoes of those who you serve very early on in their tenure is a key foundational step on the people side. The other side of the people side are the very people that you serve as an organization, and really thinking about how do you build an ongoing sustainable infrastructure to always be hearing from those who you serve. And we like to think at CACP and at CCA, we like to think of our consumers or members or patients as experts by experience. And really, in order to truly create an empathic organization, we need to be combining the expertise that I would argue we all bring to the table. We are all experts by training. This is our profession. These are our careers. We need to marry that expertise by training with expertise by experience as we develop infrastructure and we make decisions about programming and services and care model. So that's another really key piece to the people. So then you think about the process. Well, okay, how do we do that? How do we actually really leverage the people, both inside our organization and those we serve? And there are a whole number of ways that we can do that. One of the foundational steps that we think about at CACP is journey mapping. And I know that lots of folks know journey mapping. And every time I talk about journey mapping, I ask people in the audience to raise their hands if they've ever done journey mapping. And almost everybody raises their hand. And then I say, and how many of you have that journey map as a sort of living, breathing document that serves as a foundation for your decision making? Versus how many of you have it sitting in a drawer, a folder, a binder somewhere that you did as a one and done. And most people, it's a one and done. And it's something that seems to be helpful in the moment. For a lot of folks, it ends up being sort of a process map and not really an experience map. But if we really do journey mapping well, and by that I mean actually really understanding, not through our lens as organizations, but through our consumers' lenses, what it is that they're experiencing through their whole journey with us, whether it's a whole organization or a part of an organization, what does that actually experience look like? What matters most to those individuals? What doesn't work for them? And really importantly, how do they feel? Again, part of empathy is getting to the emotion. So if we really do that together as a foundational step, that really helps us begin to shift the culture of an organization. We find in the work that we do that I can say actually all the time, we find that the difference when we actually work with folks internally and we say, talk to us about the journey that your patients or your consumers go on, experiences that they're having, and let's think about the moments that matter and the pain points. And then we do the same exercise with those who that organization serves. We find that there's the folks in the organization get it wrong about half the time. So what that means is that if you aren't including the voice of your consumer in your decision-making, whether it's programmatic or operational or strategy or policy, you're probably getting it wrong about half the time. And that from a resource perspective really doesn't make any sense. And we sort of scratch our heads and we're like, well, why didn't that work? When the reality is it didn't work because we actually weren't looking at the problem or the issue authentically through the lens of those that we serve. And journey mapping helps us to do that. And then if we really use it as an ongoing living, breathing roadmap, if you will, or blueprint that changes as the organization changes, it allows everyone in the organization, no matter whether they face consumers or patients or they're in the back office, it allows them to keep tabs on what's really important to those who you serve as you're making decisions. So that's a really key, we think, a key foundational element in terms of build a process and building that infrastructure. And then obviously there are a whole bunch of other things that fall out from that, like, okay, once you've understood what your organization looks like, and in terms of the experience that folks are having and what's important and what's painful, how do you create improvement? And that requires its own infrastructure to maintain that voice of consumer as you're thinking about how to improve. So again, it's not a one and done. It's sort of, what does your enduring infrastructure look like to make sure that that consumer voice is present at the table, just like you have finance present, you have clinical leadership present. Again, it goes back to that thinking about consumers as experts by experience. So just a couple of those are initial thoughts about how you really build empathy from the ground up in a way that's really enduring and sustainable.
I think this is a perfect opportunity to shift to like why. So I'm gonna bring in Alpa for this. I mean, so humanistically, it makes all the sense in the world. Randy earlier kind of gave a little bit of insight to sort of why at a business level, maybe it helps curtail costs. I could see it being a strategic advantage when it comes to sort of customer acquisition, in the vein if you're a second, third, or fourth player in the market and you want to build your customer base. But if you're Stanford Healthcare, one of the most prestigious brands in healthcare in the entire country, why, Alpa, would you invest so heavily in a truly consumer-centric, human-centric organizational strategy when you're top dog in your market?
Well, hopefully we approach our brand cachet with humility as a part of Stanford Healthcare and Stanford Medicine. But I think almost for that exact reason, the brand represents the people that are delivering the care to patients. We have amazing faculty, physicians, and providers that our patients come to us, seeking care and advice. And I think that when you have such a tremendous brand, as patient experience, as marketing, and as other functions, it's our job to uphold what that brand means. And I think, it's really easy to kind of rest on the laurels of the brand. And the easiest thing that we can do is to let that go. And our CEO kind of talks about, once you kind of reach a certain level, it's actually hard to maintain a high level of service and brand integrity. And I think that if we take our eyes off of that, we actually risk doing more harm to brand integrity than actually living up to the expectations our patients and families have come to expect from us. So I think, that's one of the things that we really have to consider and be mindful of, because we certainly don't want to take away from that. I think the other thing is, given where we are geographically in the country, we sit in the middle of Silicon Valley, and maybe we can talk a little bit later about kind of what that means from an innovation standpoint. But given where we are, given the patients that we serve across our very diverse community, I think no matter where we sit in the market, our brand promise is such that we need to live up to the reputation that is Stanford Medicine. So brand is, I think, the exact reason to continue focusing on a consumer-centric, patient family-centric model.
So I want to get into measurement, and I want to get into strategy around innovation. Alpa, you just alluded to it. So I want to go there. But before we do that, because I can imagine some folks who are taking notes in the audience thinking, geez, I've got no budget. I've got very little resources. We just furloughed 10% of our staff. How the heck can I move in this direction that this great panel is suggesting and outlining and articulating? I'm sold, but how do I do it with very little budget or no budget at all? So Randy, could you jump in and maybe outline for the group what you would do if I plopped you down in a community-based hospital, barely enough to pay your salary, and you wanted to bring this approach, at least in the first year, to your new employer? without asking for more cash.
Exactly, because a lot of the very early years of our program, even some of the cases we have now, there's no budget for it, but there's a natural inclination broadly to help and work in these patients. And what I want to do is you speak with the chief medical officer, perhaps the chief of medicine or the hospitalist in the emergency department. They're going to know patients that have particular challenges and needs defined by social determinants of health. Someone doesn't really understand. Providing medical care, but we're really not figuring out what they really need. There are individuals who want collective help and a collective approach to solving these problems. And they'll give you their individual cases. Oftentimes they'll give you the same cases. And then what I would do is, which we've done, is these patients come up and say, why do we keep on admitting this person for the same need? We're not addressing the needs. This happened during COVID. We had a Teams meeting. Anybody who's, you look through the record and say, who are all the people that interact clinically with this patient? Well, the emergency department, the inpatient teams, specialty services. We had chief medical officer. We actually had legal involved too, because some of the things that brought up. Have a Teams meeting and just have a general discussion. And you'd be surprised at how much people are driven to do things differently, to figure out the problems in this patient's life and their healthcare, and to make things better. And suggestions for resources too, that may just be already out there in the community that you're not really interacting with a whole lot as a hospital institution, but those folks want to help out as well. And it's a really fulfilling process broadly, and I would not underestimate the interest in your staff to work to solve these patients' needs.
I love it. So you basically need a little bit of time from some key individuals from different departments and different perspectives who have an interest in that individual in a room, or not even a Zoom.
And have the patient drive the case. So you're not going to say, we want you to join a committee to work on these needs. Say, we want to help you with this patient that we know is challenging for you. And that's how we developed it. And suddenly everybody wants to join in that has some kind of interaction with that patient, or they hear about the successes for a new patient they have. Will you work on this one?
Yeah. So it's like a grand rounds, but as a physician, I know you can't steal that term. But with all the physicians and non-physicians who have a different stake. Love it. Great. Let's get into measurement at an organizational level. We talked about individual empathy, organizational empathy. If people in the audience are thinking, okay, I think we're doing a pretty good job, but I'd like to build a business case to do more, to do what Alpa's doing, to do what Melinda's doing. I need to measure where we're at right now as a baseline. Melinda, do you have experience? How do you measure empathy organizational wide so that you know a baseline of what you're working with and where you could strive to get to?
Yeah, so I think that, there's different kinds of measurement. So there's measuring experience, and we know, I think everyone on the call, I'm sure, does different variations of measuring the experience that their patients or consumers are having with the organization. And there are ways in those measures to get at some of the really important components of empathy. How well does someone feel like they've been listened to? How well do they feel like the person taking care of them really understands their needs? So there are a whole host of those kinds of measures that organizations can and should be doing in an ongoing way. And again, to go back to thinking about journey mapping, when one of the things that comes out of journey mapping is not what's important through the lens of a regulator or a board or someone, someone a payer or someone else. It's what's important to those that you serve. And measuring those things that are important to those you serve is actually a really fundamental component to empathy, to really understanding how well you're doing with those you serve. And in fact, there are lots of different ways to measure. When you think about what's important to folks, some of it can be done through surveys, through direct surveys. Some of it actually can be derived from operational measures. And we tend to think of operational measures as throughput, and they tend to be measures that different departments use really to drive efficiency. But if you start to look at operational measures across different departments, and you start to see that, well, for example, we have a timeliness issue here, and here. all of a sudden, that's not just a siloed timeliness issue in that one department, but the message that your patients or your members are getting is that you don't actually do anything on time in a timely way because they're experiencing it across their whole journey. So all of those are really important, we have organizations really relook at their operational metrics that tend to be very siloed and only viewed by individual departments, and look at those across the consumer's journey to really get an understanding of how we're doing with what people tell us is most important. So there are all those kinds of measures that are both, mostly quantitative measures and qualitative experience measures. But then there's also measuring just where your organization is on that continuum of partnership with your consumers and empathy. And looking at, well, what consumer participation opportunities do we have in place as an organization? How embedded, it's really assessing yourself as an organization in terms of the things we know matter with regard to empathy and partnership. And then being able to sort of track that progress over time. What sorts of partnership participation opportunities are in place? What are the tools that you have in place to foster consumer participation? What are the processes in HR, as we talked about a little bit already? So all of those are really important from an assessment perspective. And again, that's really measuring the process, not the experience and the outcome. But I would say equally as important to be able to build that culture of partnership and empathy. And then I think another piece of measurement that's really important is that you have a feedback loop, a strong feedback loop with your consumers or your patients. So, personally, when someone asks me questions or they want me to participate in something and I do that, and then I don't hear anything about how my insights were used, it doesn't feel that great. And I think the same is true for all of the people that we serve. So a really important part of measurement in terms of organizational partnership and empathy is really the strength of that feedback loop that you have with those you serve. When you've engaged them, how are they getting the results, not just of what they told you, but of what everybody told you and what you're doing with those results, so that they understand the impact that their insights have had in the way you as an organization make decisions and create programming.
Love that. It's a great segue to let people know that in a few minutes, you can get another email from me with a feedback form about today's show, today's episode. It informs us greatly in what we do next and what our next content's going to be. And we're already planning our first quarter of next year, if you could believe it. And so to that end, what I think we'll do, kind of talking to Sherry right now, maybe we'll provide some of the aggregate results of that survey back to everyone who takes the survey. So please take that survey. You'll get multiple emails from me when it comes into your inbox. If you don't take it, you don't want more emails from me. I know that. So, but we'll also send you the results. We'll send you the results. We'll share them with you. So you get to Melinda's point there. We'll put into practice what we're learning today, at least on our end at Shared Purpose Connect. Let's talk about how empathy now gets incorporated into design and innovation at your organization. And we'll do sort of a West Coast, East Coast perspective and see the similarities and differences. So Alba at Stanford, how is that happening?
Yeah, great. Thank you. So I think one of the benefits of being a part of Stanford Medicine and Stanford University is that we have the, I think, distinct privilege of being associated with the design school at Stanford, or the D school, where design thinking was essentially really cultivated. And partnering with the faculty at the D school has been a great experience. It's actually one of the reasons why I moved from my role in performance improvement over into patient experience, because the very first step, if you're familiar with design thinking principles, the very first step is empathize. And this to me was a real distinction or additive piece to performance improvement. Melinda talked about that. And if you can start with empathy and really employ some of the principles behind user research, ethnographic research, and understanding what the unmet needs are of your patients and family members, I think that really springboards the ability to intentionally design products, services, programs that meet the needs of your patient population. And if I can, Eric, I'll talk about an example that's very, well, one near and dear to me, but very recent for us. We actually opened up our brand new hospital building, very technologically advanced building. A lot of time and effort went into construction and design, a 10+ year process. And when we were thinking about what products and services do we really want to bring into the hospital to create a differentiated experience, one of the things that we kind of went to was our user research and really talking to patients and families, caregivers, understanding what unique aspects that we could build into this physical structure. One is obviously focusing in on, again, what Melinda mentioned, the entire employee life cycle, making sure that the culture now met the intent of this beautiful new building. If you don't do that, you just have a beautiful new building. And then if we want to create a differentiated experience, how might we do that? Sitting in the heart of Silicon Valley, obviously technology is very front and center to many people. And a lot of people wanting to understand how technology could be incorporated, but it has to be intentional. Otherwise, it's actually distracting in the care environment. So we employed design thinking methodology, and we spent time talking to almost 100 different patients, family members across our various inpatient populations to understand what their needs were. And it was interesting because at the very beginning of kind of the design process, there were some hypotheses around, wouldn't it be amazing if we could actually give patients and families an itinerary at the beginning of their hospitalization, at the start of their day, every day, saying, here's what you could expect during your day. PT would come in at 2 o'clock. You would go down for imaging at X amount of time. Sounded great in concept, but when we started thinking about it and talking to patients and families, one thing we realized is hospital operations is not that precise yet. And if we're going to set up expectations, patients were like, yeah, that's great. That's useful information, I guess. But if you're not going to be able to meet those expectations, now we're actually making it worse. So what is it that we could do to help patients and families? Well, in our research, what we started to understand is what people really want is guidance, and guidance through the hospitalization stay. Help me prepare and know what to expect if it's an elective admission. If not, help me understand what I need to do as a patient, as a family member, to be ready for discharge, because the discharge process can often be nerve-wracking for people because they're leaving the 4 walls of the hospital. They're going to have to manage on their own. So what can we do to help prepare them? So we came up with this notion of the guided journey, and this is all based on the feedback that patients and families were giving us. And then we thought, well, how do we incorporate this into something that is useful and engaging to the patients and families themselves? We looked at third-party vendors and then really started thinking about, well, what are our design principles? And one of the things that we notice is people are more likely to use something if they're familiar with it. So why not design something that leverages people's own personal devices without having to deploy extra equipment and iPads in the room? And so we started to think about how do we leverage a very robust patient portal that we had designed on the outpatient side. How do we translate that same experience into the inpatient world? And so leveraging our patient portal, which we call My Health, it's built on our EMR chassis, but custom development sits on top. And how do we translate that into the inpatient world? So we came up with our top 5 to 6 features that we prioritized and worked with our technical team to actually develop the inpatient view of the patient portal. And it's very seamless. It's the only instance of it, I think, in the country or even the world at this point, where contextually the application actually knows when you move from outpatient or outside of the hospital to an inpatient stay. And the view automatically changes, and it offers information about test results, medication, who your care team members are, because we're an AMC, an academic medical center, and there are just armies of people who come in and out of the room. So understanding who those team members are, as well as providing information on medications. Those of us that live in the inpatient world, HCAPs, communication about medications is very important. understanding side effects, as well as preparing for discharge. So what are the key pieces of information that we can actually give to patients and their families who have access to this portal to help prepare them and feel better prepared for discharge? So those are just a couple of examples of how design thinking, starting with empathy, help translate into a pretty differentiated experience for our new hospital.
Yeah, it's impressive. I mean, UPMC staff, what are you guys doing over there? Similar, different?
I would say similar, and I'll take a little bit of a different approach from the technology side. So if you think of innovation can simply be an application of better solutions, and echoing a little bit of what we've heard from the other panelists of, you don't want something that is one and done. It has to be budget friendly. We know that we all have heavy time constraints, both patients and employees. So really when we think of empathy and really active listening and asking those right questions, the core of our work really does start with code design. So similar to what Elpo was saying with the kind of the core of the design, we utilize a few very simple tools, such as what matters most to people, developed by the Institute for Healthcare Improvement. We couple that actually with shadowing, where we do use some technology there using an app called Go Shadow, where it helps us really understand current state, and we're really engaging all of those stakeholders to really understand what is their perception, what is going on, documenting that information, coupling in that with existing survey information, whether it's employee engagement or patient engagement, bringing all of that together in a very transparent manner and developing teams where it's really co-designing amongst other teams, and then helping folks really connect the dots in this sense. So we've kind of developed this approach to try to simplify things, if you will. So, we don't want our model, the patient-centered value system, to be something extra for folks to do. We say, let's take an inventory of everything we're doing. How can we make this more efficient? How can we use a better application of this to improve X? So by taking all of those things, engaging folks, we're really able to then give them a more structured approach, even with some simple templates, to align these ideas to be projects that align with a department goal, an organizational goal, and performance management goal. So we really call that connecting the dots. And we do that at both levels, from the bottom down approach, working with employees. And then we actually just developed a human-centered leadership program around these concepts as well, to really help leaders, give them the tools, bringing people at the forefront, having that empathy, but really driving results, and something that can be really scalable as well.
Great. It's just great stuff going on both sides of the country. Hopefully folks are taking good notes. Incidentally, if this is too much information for you, it's going to be live on the podcast by Sunday night. Subscribe to it, and you could catch up on some of this great content that you might have missed as everything's moving so fast here. I'm cognizant of the time, so I want to keep on moving. I'm actually going to switch the order a bit, folks. I want to bring in Rose right now and talk about the future and how she sees organizational empathy evolving and what's next. So how about Rose, jump right in.
Sure. I just want to say, honored to be on the panel with everyone with such great minds, and the changes that we've made in healthcare in the past 15 years has been really amazing. It's totally a different place now. At Nemours, we started our journey with a new motto internally, and it was, from the patient's perspective, give me the care I need and want, how and when I need and want it. And I think those are kind of some of the concepts that everyone has been kind of mentioning here on the call. What are the specific things that we're doing to kind of meet those needs? But, we've gone through the leadership program training, and we've done the train the trainer, and we've done, the empathy skills and the sim labs internally. And I actually started teaching those classes with zero budget. And the reason I thought to do those things is managing the patient survey process, which is part of my role. I started reading comments, and the things that we were missing was really about the connection points. Our families weren't being heard. So the next piece for us is moving from empathy to compassion. So we know that in order to practice empathy, you have to be in a vulnerable place and kind of leave your own personal bias behind. But then how do we move past that in healthcare to improve outcomes and reduce and alleviate suffering? And that's with compassion. And compassion is the ability to alleviate that suffering and our staff wanting to do that. So as an organization, that's really where we're going internally. And I just want to add, we do the CI huddle process. You guys, I don't know how many healthcare systems use lean principles and terminologies, but one of the things that we did that helped us to understand all of the issues on the front line is the safety service issue goes from clinic all the way to the top same day. So you're responsible to report that at huddle. That's how we empower our staff on the front line to really make a difference. And that goes all the way up to top leadership within a day for resolution, so we can fix the processes. So if you're already using the huddle process, that's an easy way.
And just so everyone knows, 65% of your patient population, at least in Florida, is Medicaid, right? So you're not, these aren't, and one of the things that you said to me when we were meeting earlier was provide equitable care to everyone, which I wrote down. I thought it was a great quote.
Yeah, we want children to have the opportunity to live healthy lives and not just have equitable care, but equitable outcomes. So one of the things that we're currently measuring now is courtesy and respect. So that's one of the questions that came from our Family Advisory Council. They want to know how do we measure our compassion and our courtesy and our communication? And so they recommended that we measure that question. And so we're looking at that question internally across the organization, and we're doing, the intersectionality with race and income and insurance carrier and all those kinds of things. So the analytics help drive your improvement efforts, but it's so important to not get lost in the analytics and make sure that you're spending time on that relationship. Are we really hearing what's happening, especially with COVID right now? I don't know about you guys, but we have electronic rounds now where folks are going around with the computers and doing rounds virtually. We have to be careful not to lose the connection so we don't lose sight of what their real needs are.
Perfect segue. So two things, everyone. When we talk about equity and compassion and access, in a couple of weeks, our next live recording for the Bright Spots in Healthcare show, I'm just looking at my notes here to make sure I get this correct, is going to be September 24th at 11:30 a.m. on the East Coast. And the title of the session right now is called Building True Cultural Competency in Healthcare. And we're going to be talking a lot about healthcare equity as well. So I know it's a really important and hot topic for all of you. You can go right to the website right now and register September 24th. Also, I know we're not getting into some of the weeds and KPIs, which we want to. We're going to host another panel on this topic. We may morph it a little bit so we could dive in deeper on November 19th. So you can mark that down. My team or me will get an email out to you so you have that marked on your calendar. It'll probably be at 11:30, but we haven't confirmed the time yet. So November 19th, we'll have a kind of a part due here on empathy as a strategy and get into some of the questions that we weren't able to get into. I want to bring in maybe very quickly in the last couple of minutes, I see questions from the audience here. One of the questions I thought was worth addressing because it sort of Rose teed it up, and maybe Randy and Melinda, you could jump in with it, was around how important rounding is. And this individual says grounding is important at their organization, great tool, blah, blah, blah. But even though senior leadership endorses it and promotes it, they don't actually do it, and they don't understand how important those encounters are to color their thinking. And I'm wondering if you guys have some insights on how to get like the executive leadership at hospitals engaged in rounding and shadowing. Go ahead, maybe in a couple of minutes, maybe we go Randy and then Melinda in rapid order as we get to that bottom of the hour here.
Sure, briefly, I think it's understanding both perspectives. I mean, part of it is my role as a physician advisor. I understand what the hospital leadership's priorities are and what their challenges are. And you also hear what's going on in the emergency department, inpatients, and they're often much more connected than you would think. So you need to be able to understand both perspectives and perhaps bring them down once you have their insights of their needs, hospital leadership, and make sure they understand. You can solve their problems based on your insights you have in your patient care.
Melinda?
Yeah, I think that's great, Randy. The only thing I would add is, the importance of that executive level leadership to set the tone. And it's really challenging in organizations where the executive leaders aren't setting the tone for empathy and consumer partnership based approaches to the work. And there's no better way to, both create empathy and create some buy-in than figuring out how to get your executives to shadow or to round. And it really just takes one champion, one senior level champion in an organization to really try to make that happen. So I encourage folks to look for that. And it doesn't necessarily have to be someone right in the C-suite, but I encourage you to look for that person who has credibility and is listened to be that champion to start to make that happen if you're having challenges in the organization.
That's great. Sherry put the registration link down in the chat for our next session in September. Again, we'll keep you posted on November. I want to take this time to thank this wonderful panel, the work they put into me prior to this, your performance today, awesome, chock full of information. Subscribe to this Bright Spots in Healthcare podcast. You can listen back to this, tell your friends and family about it. Thank you guys, you were awesome. Thanks to everyone who takes the hour of their day to join us. Really do appreciate it. We don't take the time you spend with us. We take it very seriously that you're willing to give us that time. So we really appreciate it. This will mark the end of our show. Thank you again, everyone. Thank you to Sherry Keels for putting together this great group. Awesomeness. I'll follow up with the 5 of you afterwards. I know we all have meetings that we have to jump to, but thank you so much. You were great.
Thank you.
So Mark,
Thank you.
guys. Take
Bye-bye.
care.
Good day.
Bye.